Hey guys, today's topic is monitoring 101. That is what you want to know about monitoring. You are a first year anesthesia resident and you just have to brush your knowledge about the basic and advanced monitors to monitor your patient. Myself, Dr. Hemant. So, no disclosures. So first we'll be seeing some history, then basic monitoring and advanced monitoring. We won't go into details of every monitor. We will have separate video for each monitoring later. In this video, we will just brush up the basics of monitoring, which a first year anesthesia resident should know. So history. In this image, you can see a dog and they have connected to some bowl, and the bowl is connected to some rod. So what is this? So this dog, he is Jimmy, and his legs are connected to electrodes, and he is the one who has connected and recorded. He is Augustus Waller, and he recorded the first ECG ever known to mankind. So after this only, the 12 lead ECG and the 6 lead ECG which we are using in our day-to-day life has come. So he has just connected to the electrodes and it had like mercury and H2SO4, from which he recorded the electrical activity of the heart. So this is the first ever recorded ECG. It's so fascinating, right? So who is he? Werner Forsman. He performed the first human cardiac catheterization. Did he do to the patients? No, it was not considered ethical at that time, but he had to prove that if you pass a cardiac catheter to your axillary vein, it will go and enter the heart. From this, we can catheterize the heart and you can see what is inside by the different pressure differences. So the basic for cardiac catheterizations is done by Werner Forsman, who did the first human cardiac catheterization, and he did it on himself. If he hadn't done it, then it would have been difficult to find the procedures. The procedures which you are doing now, the monitors which you are using now, has been discovered after a lot of pain and sacrifice. So this is the X-ray after right heart catheterization. So who are these two gentlemen? William Gans and H.J.C. Schwann. So as we all know, the Swan-Ganz catheter. So they discovered this pulmonary artery catheter and the different pressures were measured using this EKG when they are at the different levels. The EKG is there and the pulmonary artery pressure is there here. And when the PAC is in the RA, RV, PA and pulmonary capillary wedge pressure, PA pressure, everything is there. Okay, let's enter the topic proper. How can we monitor? How can we monitor a patient? There is a monitor and many vitals are there. What to look upon? When I entered the OT during my first year, the only thing which I was asked to do is I have to monitor the heart rate and it should not fall below 60 and it should not go over 100. And similarly, I was told about saturation and BP. So I was very bored and I was like confused what to do, what is the purpose of it. The thing is, anesthesia is a mental job. You have to hear the SpO₂ sound, you have to see the monitors, you have to see the surgical field, everything. So as a first task, we are always given this monitoring in the first year. That's why I have come up with this video. We will move to the video, how can we monitor? So we have ASA standards, that is American Society of Anesthesiology has given two standards of monitoring. So standard 2 is during all anesthetics, the patient's oxygenation, ventilation, circulation, temperature shall be evaluated continually. This is what we do in the OT. But this even the monitor can do. You might ask like if the monitor is doing, but how will it notify? Obviously, we can set the alarms and if it is going below 60, as I have told in my first year, if it is going below 60, the alarm will start beeping and the person can know that the heart rate is low. So is this enough? Just shifting the patient inside the OT and connecting the monitors. Is this enough? So this they have given us standard 2 monitoring. So what is the standard 1 monitoring? A qualified anesthesia personnel shall be present in the room throughout the conduct of anesthesia. So this they have given us standard 1. You should not just attach the monitors and leave it. There should be an anesthesia personnel who should be present throughout the OT. In the ASA definition, they have given the minimum experience is 3 years for that personnel. So a post MD anesthesiologist should be present inside the OT, that is standard 1, and the patient's oxygenation, ventilation, circulation, temperature shall be evaluated, that is standard 2. So how can we monitor? We can divide the monitors into basic and advanced. So basic are SpO₂, ECG, NIBP, temperature and urine output. Advanced we have IBP, CVP, PAP, TE and IABP. So this photo I took from my OT. So we have this ECG and arterial blood pressure line, CVP and SpO₂, plethysmographic graph, temperature. We also have this different timers which we use in cardiac anesthesia. So we will see each monitoring in the subsequent slides. First, we will start with pulse oximetry. So what is a pulse oximeter? It measures the SpO₂. As we have seen in the previous slide, this graph and 100% and above it is written 167. It is a pulse rate. It was a ICR case, so it is a infant. That's why the heart rate is very high. So in pulse oximetry, first we can measure the SpO₂. That is the primary objective of this pulse oximeter. How much oxygen the blood is carrying as a percentage of maximum it could carry. So next we have tissue perfusion by pulse waveform. So it also gives this perfusion index. Next we have the pulse rate. All these things are given in here. So all these things are given in this pulse oximetry. So what are the types of pulse oximeter? One is standalone monitor and second is it comes as a part of our multi-parameter monitor. You can carry a standalone monitor in your pocket as an anesthesia resident and measure the pulse ox whenever you are getting calls from the periphery. And this part of the multi-parameter monitor comes in your OT and in the PACU, ICU, etc. So what are the sites from which we can monitor? The fingers. In the children, we can measure it from the heels, from the ear lobes, even from the forehead, tongue. It has different sites of monitoring. So how does a pulse oximeter works? So if you open the pulse oximeter and see somewhere time in the past, it has two lights. One is a red light and another is an infrared light. And it has a sensor below and you are inserting the finger in between them. So what it will do is it will pass the red light and infrared light and it has a sensor below from which the light is captured. So if an oxygenated blood is passed through and a deoxygenated blood is passed through, the amount of scattering it does will be recorded in this graph. The wavelength recorded and the extinction coefficient. This is the red light and this is the infrared red light. The red light wavelength is 660 nanometer and infrared wavelength is 940 nanometer. So it measures this reduced hemoglobin and oxyhemoglobin red here, and infrared it measures the oxyhemoglobin and reduced hemoglobin here. From these values, it will extrapolate and it will put it in its algorithm using spectrophotometry derived from this graph. It will give you your SpO₂. That is the final SpO₂ that is displayed in the monitor. It undergoes all these processes. So why does plethysmography have to play a role in this pulse oximetry? See, if you are just placing a pulse ox over a venous blood, it won't give you the value. So the artery has to be pulsatile. The capillary has to be pulsatile. If you are putting a finger, the pulsatility should be there for you to monitor the pulse ox SpO₂. So the combination of this spectrophotometry and plethysmography gives you the final pulse oximetry value. So basically the alternative current is measured from artery and the direct current is measured from the vein tissue. These pulsatile differences are computed to give you a SpO₂. But what are the limitations? Inadequate signal like anemia, dark skin, bright external light, intravenous dye, nail polish, low perfusion, and false hypoxemia is seen, for example, if the patient is having elevated PO2 levels. And there can be some low ratings, for example, if the patient is having severe TR and the patient can have venous pulsations, that can also lead to false readings. And severe right heart failure, back pressure changes, tourniquet or blood pressure above the set of pulse oximetry, and sometimes the methemoglobin and carboxyhemoglobin can give you an underestimated value. So as a gist, from the pulse oximetry, one monitor, you can measure the SpO₂, tissue perfusion and pulse rate, the types of standalone and a part of a multi-parameter monitor, the size of measurement of finger, heel, earlobe, forehead and nose, and the principles of spectrophotometry and plethysmography, and the limitations are nail polish, ambient light, low perfusion, BP curve above, and methemoglobin. So this is the summary of this pulse oximetry monitor. Next, we are going to see this ECG. So electrocardiogram machine was designed to recognize and record any activity within the heart. So as we all know, we have this P wave. Then there comes the PR interval from the start of P wave to the start of QRS. Then we have this QRS complex. And we have this ST segment and T wave. So this is the electrical record of the heart. So this provides information about the function of the intracardiac conductive tissue of the heart. So what is this intracardiac conductive tissue? Before that, we will see where all you have to place the leads. Right side lead above the right clavicle, left side lead over the left clavicle, center lead or near the sternum, and neutral lead and foot lead over the left and the right side. It is color coded, and if the patient is undergoing surgery around this area, then you can place the leads at the back. So as we discussed previously, it records the conducting system activity. So what is this conducting system? We have seen this in our school that from essay note, the conducting system sends impulses which carries along the wall of atria to the AV node, and from the AV node it goes to the bundle branches through the Purkinje fibers. So this electrical activity is followed by the mechanical activity, as we all know the different phases of systole and diastole. So this mechanical activity is recorded as ECG. So we have PR interval, ST interval, TP interval, QT interval, RR interval, and we have this PR segment, ST segment. So what does this signify? So this P wave signifies atrial depolarization, and this PR segment denotes the delay at the AV node which happens, and this QR complex gives the ventricular depolarization. This T wave gives the ventricular repolarization, and this isoline activity means no electrical activity during that time. So this is the principle, just to be aware, that usually the reference electrode negative is placed here and positive is placed here, and ECG is connected here. So if the current is passing from the positive to negative, then there will be a positive deflection. I mean, if it is going away from the positive, then it will show a negative deflection. So next we are going to non-invasive blood pressure. So you attach this BP cuff over your right arm. So what is the place we place the BP cuff? Between the acromion and the olecranon. So the BP cuff which we use, the arm circumference should have 80% as bladder, the bladder of the BP cuff, and the 40% should be the width of the bladder. So how do you measure this arm circumference? It is measured from the midpoint of acromion and olecranon process. This is the arm circumference, and your bladder length should be 80% of it, and the bladder width should be 40% of it. So what are the recommended cuff sizes? So we have 4 sizes in our OT, that is small adult, adult, large adult and adult thigh. According to the arm circumference, we have these things. So next time when you are applying a cuff, you should see what is the arm circumference and accordingly you should put the BP cuff to the patient. And they say when you are putting a tight cuff, it should not be too tight. It should allow one finger to pass inside. So cuff placement, where should you place? We will see where we should not place. It should not be applied to the limb in which the IV fluid is placed and it should not be applied over a superficial nerve, bony prominence or joint. And what is a too tight cuff? What will it do? If you are putting the BP cuff very tight, then only a little more pressure is needed to compress the artery and to match the blood pressure. So we will have a false low value. Too tight cuff, false low value. And if the cuff is very loose, then it needs more pressure to go and compress the artery. So more pressure is needed. This will produce a false high value. So what is the principle of non-invasive blood pressure? So this is not the manual method. I am telling about the automated method which we use in OTs. So the cuff is inflated above the point of oscillation. As it deflates, the pressure pulsation caused by arterial wall movement transmitted to the cuff and sensor measures the oscillations. The maximum point of oscillation that denotes the map, and from the map we are deriving the SBP and DPP. So what are the complications of applying this BP cuff? See, you are putting a BP cuff and you are putting it in cycle. So it is continuously monitoring. In OT it is okay. But in ICU you should then and there change the BP cuff size or else it will damage the underlying tissues. It will cause neuropathies. It will cause air embolism if connected to the IV lens. This is like way beyond negligence. And advantages, we have automaticity. It is simple, it is non-invasive and it is reliable. So before going to the next monitor, I'll just wake you up with this slide. How anesthesia technicians' legacy led to laryngoscope discovery. So one morning during tonsillectomy list, on opening a patient's mouth with Boyle-Davis gag, you all would have seen this Boyle-Davis gag, right? So it was a child and they had put a larger size Boyle-Davis gag. It went to uh, negotiate the cords, negotiates the open the pharynx, which made the cords perfectly displayed. So the Richard Salt, who was a technician that time, a really excellent chap, was in the theater with me. So these were written from the laryngoscope discoverer, Macintosh. So he told that Richard Salt was in the theater with me. Before the morning had finished, he had gone out. So he told them we can make a blade out of it. So what Richard Salt did is he went to the shop. He soldered a Davis blade onto a laryngoscopic handle. He made a handle attached to this, the Boyle Davis blade, which they usually use for gag. And this led to the modern world laryngoscopy discovery, which we use in our OTs day to day, and which led to the video laryngoscope discovery also later. So a technician who was there, Richard Salt, his contribution and his legacy is what we are using on our day-to-day lives, the laryngoscope. Okay, it's time to sleep again. The next monitor, temperature. So we have two types of temperature. One is core temperature and another is peripheral temperature. The core temperature is constant, the temperature of the deep tissues of the body. The peripheral temperature is variable depending on the environment. If the OD temperature is cool, then the peripheral temperature will be low. We have shown two diagrams. So what are the temperature monitoring sites? Core temperature we can monitor in the pulmonary artery, distal esophagus, tympanic membrane, nasopharynx. And it is reliable even if the OD temperatures are different. And we have this intermediate temperature sites, that is oral, rectum and bladder. In cardiac surgery, we put a nasopharyngeal probe and we put a rectal probe. And for skin, we can monitor the peripheral temperature from it. But it is comparatively lower than the core temperature. So this is the nasopharyngeal tube, and we put the nasopharyngeal temperature probe inside and it is connected to here. Here I am showing how we put the nasopharyngeal temperature probe. Next monitoring is urine output. Very simple monitoring. You just have to put the Foley's and connect it to the back. We also have this electronic urine output monitoring also. This is the just a basic monitoring which we can see from our visible lights. Drop by drop monitoring can be monitored. So how much urine should come for the patient? As we all know, oliguria definition is inadequate volume of urine production less than 0.5 ml per kg per hour in adults. If you are conducting a surgery and the volume of urine produced was 500 ml and the OT went on for like 12 hours, so that is 42 ml per hour. If the weight of the patient was like 60 kgs, then at least the patient should produce 30 ml per hour, and the patient's urine output was 42 ml per hour, so it was adequate. If it was less than 30 ml, then it must be oliguria. And in children, it is usually less than 1 ml per kg per hour. So let me quiz you. You see different color urines in three images. Three images, three different colors. What does this color signify? So first is hematuria. Second is purple urine bag syndrome, which is produced by infections, Pseudomonas and Providentia. You can see in your ICUs. Third is green propofol, produced from your propofol. I have seen this green urine only once in my life during my MD residency. So how can we monitor? As we all said, we have done with the basic monitors, that is SpO₂, ECG, NIBP, temperature and urine output. So it is very simple. Now we are going to the advanced and complicated monitoring, that is IBP, CVP, PAP, TE and IABP. First, invasive blood pressure. The arterial cannulation can be done in radial, ulnar, brachial, axillary and femoral artery. More central the artery is, the more chances of embolism. Axillary and femoral artery cannulations results waveforms that resemble changes in the pressure in the aortic arch because it is proximally located. In radial artery cannulation, when you are cannulating, hyperextension should be avoided because median nerve injury can be there if you hyperextend. You just place a roll and then you put the radial artery cannulation. And in femoral artery cannulation, you should not go and hit the inguinal ligament. These are the two commonly injured nerve and the ligament during cannulations. So before putting an arterial line, you should perform this modified Allen's test. You should clench your fingers and occlude both the arteries and release the ulnar side, followed by the radial side. So you have put the radial artery line, you have connected it to the transducer, and from the transducer you are seeing the arterial line, you have connected the pressure back to the transducer. And you will see this waveform. So what is this waveform? We have systolic upstroke followed by systolic peak pressure. Then we have systolic decline followed by dicrotic notch. Then we have this diastolic runoff and end diastolic pressure. These are the paths of the arterial wave. Then we are going to central venous pressure. The central vein is catheterized for various purposes. It can be to monitor the CVP, it can be to give drugs, it can be to give blood, it can be to connect high inotropes, vasopressors, etc., or something which is having high osmolarity like potassium or TPN, etc. So central vein is catheterized for these purposes, and measurement of CVP is often necessary in hemodynamically unstable patients if you are anticipating in some neuroanesthesia or oncoanesthesia or cardiac anesthesia. Right IJV is the most commonly catheterized central vein. Others are left IJV, right and left subclavian, femoral, external jugulars, and axillary. So I have given the most common indications for which we put the central line, central venous pressure monitoring, and drug administration like vasoactive drugs, and also aspiration of air embolism in neuroanesthesia cases. Other indications I have mentioned here. So what are the complications which can arise during CVP line placement? It can, pneumothorax can occur, arrhythmia can occur when you are putting the guide wire, and infection can occur. It is a long-standing complication. So what does the waveform interpretation of CVP means? So it has three positive deflections, that is A wave, C wave and V wave. And we have two negative deflections, that is X descent and Y descent. A wave denotes the atrial contraction. C wave denotes the contraction, that is isovolumetric contraction. That is because of the tricuspid motion towards the right atrium. That is coming up, so C wave is coming. Next, we have V wave, positive deflection. That is because of the vena cava filling into the atrium. So I remember like this: atrial contraction, tricuspid C wave, and vena cava V wave. So we have two negative deflections. That is X descent. That is because of atrial relaxation X, and we have Y descent because of early ventricular filling. That is LDS2. And these are the most common abnormalities which can be seen in the CVP, and it denotes certain things. For example, absent A wave can be seen in atrial fibrillation. And in case of tamponade, we have absent Y descent, etc. etc. This tricuspid regurgitation is also present. Large C waves and absent X descent can be present. So next monitor is pulmonary artery catheter. So what are the ports and what is connected to it? So this is for temperature monitoring, thermistor connector. This is proximal infusion port. You can connect the infusions to it. This is PA distal port, and this is for measuring the PA pressure. Then we have this RV port. From this we can pace the patient. Next we have balloon inflation port. We can connect a syringe and inflate up to 1.5 ml. So what is this pulmonary artery catheter? It is a 7.5 French catheter which can be put in a 9 French sheet, and it is 110 centimeter long. So if you are putting this pulmonary artery catheter, you have to go through the superior vena cava, then RA, then RV, then pulmonary artery, then pulmonary capillary. So if you are going through the RA, the pressure forms will be like this, and suddenly systolic upstroke will be there when you are entering the right ventricle. And this diastole will be the same. Then diastolic uplifting will be there when you are entering the pulmonary artery, followed by which when you are going to the pulmonary capillary, it will depict the CVP like waveforms which are higher pressure when you are wedging it with the capillary. And it has a protective sheet and the introducer side ports which I have already seen. This is how a PAC catheter is placed after putting the sheet. This we have already discussed. So these are the different depths. That is, if it is in the RA, it is 20 centimeter. If you are inserting till 30 to 35 centimeter, it should be in the RA. After inflating the balloon, it should direct towards the pulmonary, towards in the RVOT towards the pulmonary artery. So if it is in the pulmonary artery, the depth should be 40 to 45 centimeter. If it is in the pulmonary capillary, the depth should be 50 centimeter. And different waveforms are depicted here. So from pulmonary artery, what are the parameters we can measure? So direct measures CVP, RA pressure, PA pressure, pulmonary artery occlusion pressure, cardiac output, and mixed venous oxygen saturation. And indirectly, it gives an idea about SVR, pulmonary vascular resistance, cardiac index, stroke volume, oxygen delivery, and oxygen uptake. Next monitoring is T, my favorite, because I'm a cardiac anesthetist. So it has this steering control and the handle, cable, and we have this insertion tube and the tip. So this is put inside the mouth. It goes into the esophagus. From the back of the heart, we can visualize the heart. I have put a basic image for the first year residents. This TE provides high resolution imaging of the heart and the great vessels. So this is like the cut section of the heart, and we are seeing the LV in the short axis. So you can see how much blood is there inside the LV and how is the LV contracting. Is there any regional wall motion abnormality? It will give a rough idea. So it is used for real-time guidance during surgical procedures or interventions, basically in cardiac anesthesia or in cardiac patients. Helps in diagnosing issues like wall regurgitation, stenosis, LV dysfunction, and presence of thrombin. So interestingly, I will tell you one fact. There was one study which was undertaken in AIMS Delhi trauma department, and they used to call us, the cardiac anesthesia residents, to put the TE machine and they to visualize the emboli when they are reaming it in PFN cases, etc., etc. So we used to go there just for TE monitoring, because other things, even the general anesthetist or the trauma anesthetist will do. Just for TE, they used to call the cardiac anesthetist. So this is one monitoring. I thought I will share this fact with you. So this is our TE mission. We will see the heart in the monitor. And It can be visualized from the upper esophagus, mid esophagus, transgastric, and deep transgastric. So, what is the principle of ultrasound or TE? That is piezoelectric effect. We have seen like plethysmography, oscillometry, like that. For TE, it is piezoelectric effect. What is its orientation? It is seeing the heart from the posterior. So this is normal LV function. If the LV dysfunction is there, you can see here, like the LV dysfunction is present. So this photo, the first anesthesia demonstration, we all know. But what is this? We all know the father of anesthesia, but who is the mother of anesthesia? She is Alice Mago, an anesthesia nursing practitioner. She has administered anesthesia to more than 14,000 patients with no documented death in the 19th century. She had no MD degree, but she has administered anesthesia to 14,000 patients. Just imagine. So she, Alice Mago, has been recognized as the mother of anesthesia. Just a fact, we all know father of anesthesia, but you should know who is mother of anesthesia. And this is the ether administration apparatus. So let's monitor the heart. As I have already put this image in the starting also, heart rate, IBP, pulmonary artery pressure, CVP, all the monitors attached, and we have brushed up all the monitoring in this class.